Welcome to the NWAETC Project Echo. I'm Kent Unruh, and I'd like to introduce Dr. Joe Merrill, Associate Professor of Medicine here at the University of Washington, who focuses his work on addiction medicine, and I'm going to turn it over to him for the talk today.
Great, thanks for having me here. I'm going to talk about a few things today: the importance of opioid use disorders in HIV care, some screening and DSM definitions of substance use disorder and therefore opioid use disorder. I'll talk a little bit also about assessment and monitoring of patients who are prescribed opioids for chronic pain, because that's a common scenario where we may see patients with opioid use disorders, and then talk a little bit about opioid use disorder treatment with methadone and with buprenorphine. So as you know, injection drug use is a major risk factor for HIV infection. More recently, there's been epidemics among youth, primarily in the use of prescription opioids, but emerging evidence that those young folks who are getting hooked on prescription opioids are moving towards heroin use. We see that in needle exchange studies here in Seattle, and it seems to be both an urban phenomenon but also a rural phenomenon. So heroin is making its way into our rural communities a lot more than it used to, and we have seen increases in hepatitis C in that group, not so much HIV as yet. There's also been rising rates of opioid overdose death nationally. That's also been true here in Washington state. And all of this complicates the management of chronic pain. Patients who may have opioid use disorders coming for chronic pain or having both disorders. And bottom line is, if you find somebody who has an opioid use disorder that's moderate or severe, it does generally require medication-assisted treatment, not a detox. So screening, we talk a bunch about screening, and alcohol has been developed quite a bit in terms of screening and what to do about it. For drugs, it's not as well developed. There is a well-validated question: how many times in the past year have you used an illegal drug or used a prescription medication for non-medical reasons? And that's a single item screen. It's really quite good. A positive response is anything but never. And it captures a lot of people who have some kind of problem with drugs. It doesn't capture everyone, of course, but if you're using a screening question looking for this, it's a reasonable one to use. The DSM-5, a new definition of substance use disorder, there's quite a bit of difference. I keep saying substance use disorder. Notice I'm not saying abuse and dependence, and that's because substance abuse and substance dependence are no longer part of DSM, and DSM-5 collapses those into substance use disorder, basically combining the criteria for those two disorders into one. And there's a few things that are different. The main ones, you see tolerance and withdrawal right at the top, but the DSM-5 now says that if you're taking a medication as prescribed and you develop tolerance or would go through withdrawal if you stopped it, that doesn't count as one of the criteria for substance use disorder. Notice you do have to be taking it as directed, and that's often a problem for folks who are actually having trouble controlling the use of prescription medications. So it can count as a criteria if they're not using it sort of to the letter. And then these other criteria you may have seen before: trying to cut down or quit, spending a lot of time dealing with getting medicine or obtaining them or recovering or taking them, using more than intended or giving up important activities. And basically, it's use in spite of consequences is the main thing. There is a new question in DSM-5, and that's craving. So you can ask that, such a strong urge that you could not think of anything else. So that's a criteria that wasn't in DSM-4, wasn't in opioid dependence, but is in this new definition. So that's the criteria. It's really, there's not really the only thing that saves time is that a lot of people have all of them. So you get through a few and you say, okay, they got a lot of them. I don't need to go any further, but you do have to kind of go through them. So they're also new in DSM-5 is there is a severity measure. So if they have if they have one only, that's actually not a disorder. If they have 2 or 3 of these criteria, that's a mild disorder, and everything else is moderate or severe. So moderate or severe is really more akin to what we used to call substance dependence or addiction. So folks who are looking at a diagnosis that might get a medication-assisted treatment for opioid use disorder, you think of it as 4 criteria or more. There's another context where you may be assessing patients who are potentially going to get prescription opioids for a chronic pain condition. There are a number of tools that have been developed to try and figure out who's going to have trouble with their prescription opioids. I hesitate to say who's going to have an addiction problem because the addiction criteria still don't work that well in the setting of opioids being treated for chronic pain. The changes they did in DSM-5 help, but may not help enough. This is the kind of survey, this opioid risk tool is a common one. It talks about family history and personal history of drug and alcohol. And then age gets you a little bit if you're young. If you've had pre-adolescent sexual abuse or psychological disease, you get some extra points. And this is a way to sort of screen general risk if you're going to be prescribing opioids. There are other tools like it. The main thing to know is that if you have a history of addiction, you're high risk. And if you have a lot of mental health problems, you're high risk. So getting an addiction history can be tough, sometimes in the medical setting. Sometimes when patients don't have any reason to hide what they're doing, then it's not really a problem. But sometimes, like if they have a pain problem and they want an opioid medication, they may be more reluctant to disclose their history, and you kind of have to figure out what's going on anyway. And really, the establishment of rapport, listening to people about their pain, diagnosis about what's going on with them, and responding in an empathetic manner is really the best way to get people to open up. If you are going to ask about addiction, start by asking about it when they were younger, what happened to them when they were a teen, and that kind of thing. A lot of people are less defensive about what happened long ago, and you can sort of get a sense of how bad it was back then, and that's going to give you a lot of information about what might be going on now. Even if folks aren't willing to tell you about what's happening now, or you're not sure about their story, you can get information by asking about the past that's really relevant. So you're assessing past problems, past treatment efforts, and you're demonstrating that you understand this is a difficult thing to change behavior, and maybe they got a lot better for a while, and then trying to find out if they did have bad problems. Is there kind of a recovery story attached to that if they're reporting no use? Like, usually it's not that easy to stop. So have patients talk about that a little bit. And if people have had severe problems in the past and are using currently, even if they're not using at levels that they admit are problematic, that really puts the risk, and that's whether it's alcohol or drug, it puts the risk much higher for folks that they may, if they aren't using a lot now or having troubles, that they will develop troubles. So monitoring people, I'm just going to talk a little bit about opioids for chronic pain. If you're on, because this is a scenario where people sometimes present with an opioid use disorder, it's really recommended for chronic pain that you use universal precautions basically for all patients, which means that everybody who's getting ongoing opioids for a chronic pain condition gets monitored, and that's generally with urine drug screens and prescription monitoring program checks. That's kind of the basic couple things that you can do, and if you may do it more if you have somebody at high risk, but you're going to do it for everyone. And the substance use disorder history, or the other risk factor, if people have been on high doses of opioids, that's actually a risk for having problems with opioids, not responding well to them, and having problems with them. And then the kinds of behaviors you're familiar with, early refills, they lose their medicine, or there's something in the urine, or there's some other doctor involved and you see it in the prescription monitoring program, those can really indicate safety issues, and you really have to do something about them. So you're doing the monitoring. If you get a positive result, you kind of have to do something, and what that can be is depends on how safe the situation is. If they overdosed and needed Narcan in the ER, it's pretty different than if they missed their physical therapy appointment or missed an appointment with you. But you got to do something, and often that's intensifying treatment, doing a little more, getting a little more information, and seeing if basically the wheels come off as you watch them more closely. But your goal is not to fire patients, say, oh, I caught you with cocaine in your urine, you're out of here. You're really trying to engage them in care, and if you're trying to make a diagnosis. And if somebody has a diagnosis of an opioid use disorder or another substance use disorder, you want to make that diagnosis and try and get people treated. Don't fire people. You may stop their opiates, but don't fire them. And some patients, especially if they've been on high doses of opioids, may really require addiction treatment and medication-assisted treatment, because nobody comes off high doses of opioids easily, whether they're being prescribed for pain or taken recreationally, or most people who end up looking at treatment for an opioid use disorder are no longer taking their opioids recreationally. They're taking them to avoid being really sick. So treating opioid use disorder, they require specialized treatment. It doesn't mean it can't happen in your office, but you need to understand what has to happen. Methadone maintenance is the most effective modality for an opioid use disorder. In that context, patients are treated basically with daily supervised dosing. They go 6 days a week. They do get one take-home generally on Sunday. They get counseling and they get urine testing that's monitored, observed urine testing. Stable patients, after they've been in treatment for a while, can get take-home doses. Actually, they can get up to a month's supply of methadone out of a methadone program if they've been in treatment for an extended period and done really well. People who are in methadone treatment longer do better. People, unlike in the context of pain management, higher dose treatment, if you're talking methadone maintenance, actually does work better than low dose. And so most patients are treated with doses in the 80 to 120 milligram range, which is way, way, way higher than what is recommended for chronic pain treatment with methadone, where doses in the 20, 30, 40 range are really kind of the top. Methadone maintenance is way superior to any kind of detox. Most people don't get through a detox. And even when they've taken patients on methadone and tried to give them a lot of psychosocial support and taper their dose slowly and carefully, those folks don't do as well as people who are just stay in methadone treatment. So you generally want to recommend that people who are in methadone stay there until their mental health, their medical, their psychosocial issues, maybe their legal issues or housing issues are really stable before they try and come off the medication. When you talk to methadone patients, you really want to ask them about how they're doing in treatment. And the best way to do that, ask them about their urine test results and ask them about how many take-home doses they get. Like if they're early in treatment or are kind of unstable or missing appointments or having drugs in their urine, they will still be getting just the one take-home dose every week. If they're only going twice a week to treatment, that means they're doing really well and they've been stable for quite a while. So you can look at that as a way of judging how well they're doing in treatment. And you can also watch their dose. What is happening with that? Are they trying to get off too soon, or are they not willing to go to a dose where they're actually suppressing their opioid use? Those are kinds of questions, and it's worth asking. They don't necessarily trust the methadone program to give them good advice about their methadone treatment, and you're in a position where you can. So advise them to stay in treatment until their problems are stable, and if they are reluctant to stay in treatment a long time, you can also talk to them about the extended take-homes that are an option. Methadone maintenance programs are not going to take your patient if they call up and say, my doc stopped my opioids for pain and I need pain treatment. The methadone program won't treat them. They'll only treat patients who present saying they need help with their addiction, because that's all they're allowed to do. So buprenorphine is the other option for an opioid use disorder, and it is something that you can learn how to do and do in your office, and I encourage it. There's federal legislation that made this office-based kind of treatment of addiction legal. Methadone is not legal to use in the office-based setting for addiction treatment. It has to be done in these specialized programs. But buprenorphine is the only medicine that fits into this category of medications that can be used for addiction treatment outside of an opioid treatment program. You have to do an 8-hour training and obtain a federal waiver. Both the docs next to me have done that and have treated patients with buprenorphine. If you do the course, though, you're going to get more than a waiver. You're going to get a better understanding of opioid addiction treatment. It's going to help you if you're trying to manage patients on opioids who have chronic pain as well. And really, it's a very gratifying form of treatment. There's not a lot we do in primary care that's as dramatic as helping someone who goes from really out there with an addiction to being stabilized on a medication and doing better in their life. And it also saves lives. So buprenorphine is what we call a partial opioid agonist, and that means that unlike a full agonist, if you give more and more of it, the dose is down on the x-axis there. If you give more and more of it, it only has less than a maximal activity at the opioid receptor. So that makes it safer. If you give a full agonist, higher and higher dose, you'll end up with an overdose risk. But a partial agonist by itself is very unlikely to cause an overdose. It doesn't really happen unless there's other drugs involved. So it ends up being a safer medication than methadone. That's one of the reasons that buprenorphine is used in the office-based setting. The other aspect of buprenorphine is its receptor binding potential, and these are slices of brain, and the top one is a normal brain with with the opioid receptors lit up. And you can see in the second row, that's an addicted brain on no medication. And you can see that the opioid receptors are lit up all over the brain a lot more widely. This is one of the changes that takes place in the brains of folks who have opioid use disorder. If you give them buprenorphine, though, and then try and light up their opioid receptors, that's the third row. And at 2 milligrams, you can see that lots of those receptors are blocked by the buprenorphine. And if you get a dose up to 16 milligrams, like the bottom row there, most of the opioid receptors in the brain are blocked. So buprenorphine is blocking them by having a high receptor affinity, and that's how it works. So if they use heroin while they're on it, they don't feel it, and that's a good thing. They tend not to do it anymore. This is a different mechanism of action than methadone. Methadone basically works by increasing the tolerance to opioids. And so folks on 80 to 120 milligrams of methadone, if they use heroin, they basically don't get much effect at all because the methadone has made them so tolerant. So a little bit different mechanism for buprenorphine. Buprenorphine's been shown to be superior to a detox or to psychosocial treatment alone. The longer duration, again, is more effective. So keeping people in treatment is one of the key indicators of effective treatment. The drug use outcomes, if you look at people on methadone and on buprenorphine, are pretty similar. They both use a lot less opioids and get a lot better in their life. But methadone is superior to buprenorphine in retaining patients in treatment. We don't understand exactly why, but it's about a 15 or 20% difference. That doesn't mean that everybody should be on methadone, because buprenorphine can be delivered in an office setting, and that can be a big advantage for people, and is often the first place that people will go. Certainly if I had an opioid use disorder, I would want to try Suboxone, buprenorphine before going to a methadone program. It's a lot less restrictive, and you can do it in a physician's office. Some physicians who do buprenorphine restrict their prescribing. You do have the option of putting your name out there as somebody who accepts addiction treatment referrals, but you don't have to do that. You could say that I'm only going to treat the patients in my own practice, maybe those in the practices in the group that I work in, but most practices that take care of folks with HIV are going to have some patients with an opioid use disorder, and you may be able to help both your own patients and your colleagues' patients get a lot more stable and be able to deal with their HIV as well as their addiction more effectively. So I'm just going to have one more quick thing about overdose prevention. This is kind of a newer area of trying to educate people about opioid overdose and give them naloxone. It's kind of an emerging harm reduction strategy that's being used across the country more and more. It started off kind of as a community-based, grassroots sort of effort in some needle exchanges to train people to use naloxone. Naloxone reverses opioid overdose, and people have to understand what an opioid overdose looks like, what to do about it besides giving naloxone, and not to do CPR, but to give them naloxone and make sure that people are breathing and breathe for them if they're not, and then give them naloxone. So there's education strategies and then the provision of naloxone is actually now being advocated at the federal level. So those people who are at high risk of an overdose or their family or friends, it can include people who are going to needle exchange. People coming out of jail or prison are especially high risk of an overdose, and trying to get this medication to them. And then people in drug treatment, methadone maintenance treatment, we're starting at one of the programs here to give out naloxone to that population. And then folks who are prescribed high doses of opioids or who've had trouble controlling their use, you may have to get them off the opioid, but an alternative is, or not necessarily an alternative, but in addition, naloxone and education is a good idea. There's a website there that has a lot of information about this. It's not in many pharmacies, so I can't tell you can just but there are some pharmacies in Seattle that are doing it, and I think you'll be seeing more of it. It is available in Seattle at the needle exchanges, and I think is starting to spread around the state to some degree. So that's really all I've got. This is just a summary. Opioid use disorders play an important role in HIV management. The screening and diagnosis is really the key to deciding what to do about folks. It can complicate our management of chronic pain, and really it's important for us to be monitoring our patients with a universal precaution approach to try and make sure that we're not giving opioids in an unsafe manner, and that people get their diagnosed and treated appropriately. And that effective treatment is really available.